were gathered here for a very important meeting that brought together the Ministry of Health, academia, stakeholders and partners to disseminate results of a very important study that was done on the effectiveness and impact of oral cholera vaccine that was done by the University of Zimbabwe in conjunction with Zim FETP. So we gathered for that important thing. It's important on our cholera calendar as we move into the season of cholera. You might know that the rain season presents an increased risk of cholera. So this was opportune, this was right on time. The discussion highlighted one of the key interventions that we use in cholera prevention and cholera response, which is the use of oral cholera vaccine, commonly known as OCV. You might remember that last year we deployed OCV in what we term the hotspots for cholera. These are areas where you are likely to have cholera because of increased risk factors in those areas. So we're here now to review what is the impact. And we are glad to inform the nation of Zimbabwe that from our study, which is local evidence that we have generated, we have seen that OCV is effective. It protects from cholera by a factor of around 40–45%, which is in conformity with what we find in literature and other similar settings. So this is a vaccine that we continue to advocate for, where it can be deployed. It's not used alone, because alone it's not as effective as it should be. It's used as part of a toolkit. But key or anchor intervention there is to ensure that water, sanitation, and hygiene is provided in our communities. This is what is very important. But in addition, OCV actually helps us to sort of work on our WASH solutions, which are medium to long-term interventions. But in the meantime, we need to ensure that the population of Zimbabwe is protected from cholera. So the key takeaways from this important gathering today is that we need to ensure that our response mechanisms are up to scratch. We have what is called the incident management system, which is a structure that we use to systematically respond to any incident, cholera in this case. So we need to optimize that system. We also realize the need of multi-sectoralism. So the prevention, the treatment, and the response to cholera is not just under the purview of the Ministry of Health, it's the whole of government and the whole of society approach. So we advocate for our partners, we advocate for our colleagues within the MDA fraternity and the partner world to ensure that we work together as stakeholders in preventing, in responding to the cholera outbreak. One of the issues that really emerged from this meeting is the mapping exercise that we did to try and focus and stratify our country into hotspots, which we commonly call priority areas for multi-sectoral interventions. It's an exercise that we did to see where the highest risk lie, so that we focus our interventions in those areas. You know, resources are scarce, so we need to focus and ensure efficiency. So we identified around 276 wards in Zimbabwe where we need to prioritize our interventions. So we're sharing with partners here, stakeholders, the academia, those priority areas for multi-sectoral interventions. And within those areas and other areas in general, we have now intensified our epidemic preparedness and response activities. And I'm glad to reassure Zimbabwe that we have already pre-positioned commodities. So these are response commodities that we use for cholera response. For example, we use tents as cholera treatment camps, so we have pre-positioned those in provinces and districts, particularly, and with scientific bias to areas which we feel are hotspots for cholera. So we have done that. Commodities like fluids that we need for rehydration, medicines, and in addition to that, we have human resources that is trained, what we call rapid results teams. They are on the ground, they are sensitized, and they are ready. And their primary function is to do surveillance. But for surveillance to happen, we also need the community to be involved. So the village health worker network, the community health worker network is now heightened to look for possible suspects of cholera so that they are referred and laboratory confirmations can be done and response activities can be instituted. So in terms of readiness, we are ready for the cholera season, but I urge the community to also participate in surveillance activities. Where you see those with diarrhea or suspected cholera cases, please report to the village health worker close by or the nearest health facility so that we institute our rapid response teams for scientific investigation, for immediate response so that we prevent community transmission.